Hello. Good evening, everyone. Thank you for joining us. Welcome to this second webinar of the trilogy series on the EAS ESC Dyslipidemia Guidelines Explained and what they mean for patient. I'm really happy to be there with you tonight. My name is Marina Leroy. I worked for FH Europe Foundation since last summer as the Scientific Communication Manager. And I'm really happy to be moderating this session tonight. Bear with me, it's my first moderation, so I think everything will run smoothly, but we have amazing people on the panel tonight, so I feel like it's going to be an amazing webinar. Last week, in the first webinar, we looked at the guidelines and how they are developed and how evidence is assessed, etc. And with amazing participation from the panelists, so Professor Borgen Ordesgaard, and as well as Professor Albert Wigman, and also, of course, our really important Elsie Evans from the foundation, as well as Magdalena D'accord, the CEO. And this week we'll go a step further in these guidelines, and we'll aim to make these guidelines more accessible and relevant from a patient perspective. So that's why here tonight we will discuss why updated guidelines were needed in 2019 and who they apply to, or cardiovascular risk is assessed, etc. So for this, I'm really happy to introduce you with the speakers that we will have tonight. So tonight, I have the pleasure to introduce you to first, Dr. Julia Brandt from Germany. So Julia is both a clinician but also a researcher and very involved in the study of FH and statins and high cholesterol. Then we also have Dr. Antonio Gallo exercing in France, so at La Pitié-Salpêtrière, also a researcher and having a lot of patients on a daily basis, patients with FH and FCS. And last but not least, we're very happy to have also on this panel to share the perspective of patients, Neeraj Avenu from Germany. So originally from India, but living in Germany. We will share also our experience about what it means to live with elevated Lp(a) and what was a kind of diagnosis process and how this was managed between India and Germany. So before going too deep in the guidelines, let's have just a recap of the housekeeping rules. So just as a reminder, this session will be recorded. Then the recording will be available on our YouTube channel. You can already, if you have missed the first webinar, it's already on the YouTube channel. And if you have any questions throughout this session, don't hesitate to submit them to the Q&A, and we'll try to answer as many as we can during this session with the panelists. And you can use the chat to introduce yourself to the other participants. And now I think it's time to deep dive into the guidelines and have a presentation by Julia. We're really excited to know more about these guidelines, and I know that you've published also a very interesting article about the implementation, optimal implementation of these guidelines based on the Da Vinci study. So very interesting article showing like the challenges around these guidelines. Part of your research project, and we're really happy to have you on this panel and to learn more about these important guidelines for the community. Thank you so much. Floor is yours.
Thank you, Marina. Thank you, everyone, for joining today. And I'm really excited to talk about this topic. And to do so, of course, we have a little presentation to give us some ground for discussion. And so what I want to bring to you today is a very, very brief recap of the 2019 guidelines, how we can understand them, and what is still important from these guidelines up until today. So, and to understand these guidelines in 2019, I want to bring you a little bit of history so we understand how this guideline developed and where it's coming from. So in 2019, we had the ESC EAS Dyslipidemia Guidelines. This is what I'm going to talk about further. But in the beginning, there was, in the early 1990s, there was a first European Society CVD prevention guideline. And this guideline actually was the one that was further developed. And it was just in 2011 that there was a switch from a general CVD prevention guideline towards a dyslipidemia guideline presented by the European Society of Cardiology as a joint venture together with the European Atherosclerosis Society. And I think this highlights very nicely how important dyslipidemia, or high cholesterol on its own, is as a cardiovascular risk factor. And this is why we're looking at it. So it even got its own guideline and made its way from the CVD prevention guidelines. So 2011 was the first dyslipidemia guideline, and then there was the next one that came in 2016. So you see, normally there was an average of 5 years between these guidelines. But in 2019, there was this next guideline coming. So very nicely, not only these European guidelines stand on their own, but a lot of national guidelines are oriented on these ESC guidelines. Why? Because these are expert guidelines that are based on all the scientific literature. So not each and every one society on the national level has to redo this work, but they rely on the ESC guidelines. And for that, for example, in Germany, yes, the German Cardiac Society, they align with the ESC guidelines. However, for example, the GP guidelines, they differ a little bit. So even though we have this general European guidelines, there might be on a local level also others. So what was different in 2019? Why did we need new guidelines there? And there are four key issues that arose during that time. So the first one was that there were a few huge trials that had been published that were able to show that lowering LDL cholesterol below the levels that we could achieve before is actually safe on the one hand, but it also gives you additional benefit in terms of preventing stroke and heart attack. That was the first impact. Secondly, we had new medications, and not new medications in terms of another tablet, but we had a whole new class of treatment available. These are now called PCSK9 inhibitors or injectables. And I will talk a little about this further down the line, but these new class, it was important that we get some guidance on how to use them, when to use them, in which combination, and so whatsoever. Thirdly, it was also acknowledged in these guidelines that we would require stricter targets, and that is in line with the point above, that lower LDL is safe and achieves more cardiovascular benefits, so less heart attacks, less stroke. So we were safe to move the new treatment targets lower. And further on, the guidelines also acknowledge that we saw a huge undertreatment across Europe. So real-world data already showed that there is an issue with implementation. So the 2019 guidelines tried to be more explicit, clearer, and had more actionable recommendations. So for whom are these guidelines? So actually, these guidelines are written for cardiologists, but also for GPs, families, doctors, and other specialists across Europe. But the patient population they are covering is huge, and actually in the end they are relevant to every patient because we all have a heart, we all have a vascular system, and we all want to keep it healthy. So the first group of patients are those with coronary artery disease. They get some very specific recommendations in terms of how to treat their risk, how and when to use which lipid-lowering treatment. Similar for patients with a stroke or for patients who have an issue with the arteries in their limbs, but also for patients with diabetes. Especially the 2019 guidelines gave recommendations for patients with diabetes. Familial hypercholesterolemia, specifically addressed within these guidelines. Patients with chronic kidney disease, elderly patients, but also those patients that do not yet are patients, but just people going around having no issues, but maybe some yet undetected risk factors. So I want to highlight, because when we as clinicians talk about the guidelines, we are very, very quick, and I will show you later on why we are very quick to move to the field of pharmacological therapy. However, the 2019 guidelines and also the upcoming have a special section on lifestyle recommendations, and they explicitly say that lifestyle recommendations come first. So the basis for all cardiovascular disease prevention is lifestyle, and that applies to all of us, whether it's what they call a heart healthy diet, so a reduced intake of trans fatty acids or saturated fats, an increase in fiber, so more vegetables, more greens, but also regular exercise. The recommendation is 150 to 300 minutes. We can all check for ourselves if we did this week. I certainly haven't, I'm sorry. We should all stop smoking or not even start. Manage our weight, limit alcohol. So alcohol consumption is recommended to 0 grams per week in these guidelines. And of course, I think that is among the hardest to manage our stress levels. So when we want to start to treat dyslipidemia, then the first question we have to ask ourselves, is our patient at risk for heart attack or stroke over the next coming of decades? And how we think about this is a little bit different than, and I mean, we as clinicians, is a little bit different than you would usually think about it, because we are thinking about risk in a very narrow time frame of 10 years. And we have certain tools at hand that can tell us whether your risk is high, that means over 10 to 20%, to have a stroke or a heart attack within the next 10 years. But always we start by trying to categorize patients into at least 4 different groups of risk. And this is then where we base our recommendations on to the patient. So what does this mean? Firstly, we look, does our patient have any comorbidities, or does he already have like established a coronary artery disease, meaning did he ever had a heart attack or a stroke? Does he have severe kidney disease or familial hypercholesterolemia plus an additional risk factor? Then these patients would directly fall into the very high risk category. High-risk patients are, for example, some patients with diabetes or patients with uncontrolled high blood pressure. And then we have the category of moderate risk and low risk. So I think it is important that you understand there are several categories, and go have a conversation with your treating physician and just ask him, what do you think is my risk category? Even if you do not have some of the defining illnesses, he will then pull up a calculator, for example, SCORE2 or something, which is just a tool that shows a person with your profile of age, blood pressure, cholesterol, how likely is he going to have, if we look at the whole population, how likely is he going to have a heart attack within the next 10 years? And from there on, we then have a discussion whether you would require more than just lifestyle intervention, whether you would require pharmacological therapy. So this is the first step. Get it straight. What is your risk? Because now what follows is when we have the risk categories, the ESC 2019 guidelines very nicely gave us a target LDL cholesterol. And patients who are in the very high risk category should attain the lowest LDL cholesterol levels. This concept is actually not new. It was again there in the 2016 guidelines, but the targets were different. But due to these huge studies I told you about in the beginning, we were able to decrease safely LDL cholesterol targets among the different risk categories for patients. Patients who land in the high or very high risk, per definition, do or are recommended to have pharmacological treatment to achieve at least a 50% reduction in their cholesterol levels, and on top then to reach these 2019 target LDL cholesterol levels. So how does this treatment look? Typically, we move along a certain ladder of treatments, and the basis for this is always the high-intensity statin. If you have treatment and you want to start with a monotherapy, it should be the high-intensity statin. We also know from many studies that a lot of people with a statin therapy alone, so that only this one drug, are unlikely to achieve a goal, for example, of 1.4 or below 55 milligram per deciliter. So that's why the combination therapy of statin and ezetimibe is much more common, because both medications can then work together to lower LDL cholesterol from your individual baseline level, not only by 50%, but also through the addition from ezetimibe by 20%. Then, even though I'm talking about the 2019 guidelines, I'm now sneaking in here to be correct, the bempedoic acid. Bempedoic acid is a quite recent addition to our armamentarium to lower cholesterol, but it has not yet been addressed in the 2019 guidelines because entering market was later. But the PCSK9 inhibitors have been mentioned in the 2019 guidelines. And they were given a very strong recommendation, but we have other issues, mainly costs with PCSK9 inhibitors. But this is the common ladder. If you were to escalate your treatment, you would go through these steps. So, and I just said it, I mean, guidelines, they reflect what we should do in light of the scientific evidence. But this does not necessarily align with what we see in real world and with the barriers and opportunities we have to work with within the real world. So I have listed here a couple, and this is not, this list is, of course, it's not complete, but there are some that are important to me, and I see each and every day in clinic, for example. Actually, patients are afraid of side effects, and hypercholesterolemia is something that is not hurting anyone at first instance. So hypercholesterolemia you do not feel on its own. So now having a treatment that is just focusing to reduce your cholesterol, which might have side effects, is kind of scary. And I understand that. So there is a recent publication that very nicely shows that all the side effects, for example, that are listed in the descriptions that come with a statin are a little bit exaggerated. So what you can read there is not necessarily what will happen to you if you take these medications. On the other, they are actually very, very safe and well tolerated. Then there's an issue if you take several medications. The more complex the treatment regimen gets, as you get something like a pill burden, and that is not easy to handle. And it's this shouldn't be on the patient's shoulders alone. We as clinicians, for example, we should try to prescribe combination pills. So the pill burden itself gets lower, even though we prescribe the same amount of drugs. Cost and reimbursement is an issue, especially with these costly therapies like a PCSK9 inhibitor, but also like if you want to get a prescription for a statin, and in some countries you have to pay a certain fee to fill in your prescription or to go to the doctor. This can be a barrier. And then we are all humans, so unintentional non-adherence, what do I mean? We just forget to take our tablets, or we forget to get the refill. In addition to these scope, then we have also the healthcare system barriers. Care is not accessible to everyone, unfortunately. Some do not know that there would be a need of care. Some doctors underestimate the risk of cardiovascular disease. Some doctors are not aware of guidelines or the newest update of the guidelines, or with the newest treatment and treatment targets. And also there's a lack in resources, so referral can be delayed. So to conclude, what do I want to, if you are a patient, what do I would recommend to you after this webinar? What could you do? And therefore I collected this set of questions. You could ask your doctor to just start a conversation with them to get into control of your own risk. And that would be, first, ask your doctor, what do you think is my risk category? Secondly, what is my LDL cholesterol target now according to those guidelines? It is interesting if he will go to the ESC guidelines, or maybe he will go to national guidelines and make recommendations according to those. And also, if I am in a higher risk category, do I currently reach my LDL cholesterol goal? Most of us may probably have to have a blood test for that. And do I need to either adjust if I already take medication, or do I need to take medication? And if I get medication or not, when should I test next? And with that, I'm very, very curious to hear your thoughts and to dive into a lively discussion, hopefully.
Sorry, thank you so much, Julia. It was very interesting, and I think it's probably very insightful for the whole community, because going through this nearly 80 pages of of the guidelines, I think it can be very overwhelming when you see the document. But I really also enjoy the way you presented that. Really, it's like the new research, the new evidences that are really driving the new treatment, the guidelines, and that's really supported by strong research and always updated to provide the patient the best, even though, as you said, accessibility remained something really difficult depending on the country people are living in. Also, I think it's a great thing, like your last slide with the questions for the patients I think it's super useful. I think everybody, like with FH or without FH, or any patients or non-patients, we should all be aware of our numbers. There's a whole campaign about know your numbers. I think it's very relevant that we should have this tested, and if needed, if we are in this kind of risk category, we should be aware of it and follow up and be more involved in the process. And it's I think it's great to see, and to see that also patients should be empowered and really driving this. I think we'll have a lot of questions from the audience about this. If you don't mind, I will now move to the more daily practice and have the opinion of Antonio Gallo about what's happening on the daily practice when it comes to discussing these guidelines with patients. So, Antonio, you're seeing many patients every day with FH or other conditions. How do you manage to discuss these topics about when it comes to risk, to target, to this like 10-year risk of having a heart attack and stroke? I think it's probably very difficult for patients to capture all of this and understand why they have this medication, and maybe they know someone also with high cholesterol who has a different treatment and why it's not the same, and all of this information. How do you cope with that?
Yeah, thank you for this question, and thanks again for the invitation in this very interesting webinar. Julia nicely introduced all the challenges also that we face when we have to explain the complexity of these guidelines. And I want to say that in the clinical practice, we do not necessarily do at first with patients because there is too much information, as you've been able to see, and all this information cannot be, digested in an easy way and in just in the time of an outpatient visit. So, of course, there is a graduality in the communication, and we maybe start from priorities. So when we have patients who have already experienced cardiovascular disease, the job is easier because they have lived the risk, so they have an exact perception of what it means to be at very high risk. So they have been, unfortunately, by experience, in touch with the issue, with the outcome. It is a bit more of a challenge when we talk to healthy people, to people that do not have, apparently healthy people, to people that do not have experienced cardiovascular disease, but are at risk. So the transmission of the information on the risk is something that needs to be communicated at multiple steps, I think. So of course there is, it depends also on the level of interest of the patient, meaning that there are patients that are more aware of what of the reason they are consulting and of the risks they are facing, because probably in the family there have been already some experiences. So we can start from that and explain that the fact that they have the chance to come before the event just, gives them the opportunity to prevent that the history repeats. So this is some, practical aspects in order to try to let them refer to something that is still present in the family and that comes back to their own experience to have something to compare to. When it's about communicating risk, there are different tools that can be used that are proposed by guidelines in order to actually try to give an information on how life expectancy, for example, can be reduced or increased when we are not exposed rather than being exposed to a certain cardiovascular risk factor. And so with some tables that can, show these trajectories, we can sometimes try to illustrate these risks. This is something that can speak more or less to the patient. So it will always depend on which is the demand from the patient, which is the actual question that the patient is answering. But we have some tools that we can sometimes use to explain this the risk of these trajectories.
Okay, so yeah, you need to adapt to every
Mm-mm.
situation. That every patient is different. So the communication, but also like the trajectory will be different. But are there any differences in the French guidelines? And if there are, how do you manage navigating with national guidelines and European guidelines? How do you use this?
So we actually have some differences, and I think that this is something that applies to several countries in Europe, and not only in Europe, meaning that national guidelines, as compared to the European ones, are sometimes a bit, restrained by economical issues or regulatory aspects for which access to treatments are not necessarily the same between countries. So what is stated in the guidelines cannot necessarily be applied in the clinical practice. This happens in France, for example, with PCSK9 inhibitors, just to give an example. And sometimes this is what is really challenging for us, because we have patients that ask about these treatments to us, and we have to explain that unfortunately these treatments are not available. So following the guidelines means also to be able to, cope with what's available in the country. So sometimes if patients are skeptical about our conduct, we need to explain all these obstacles that sometimes we are facing. And sometimes within the family, you have patients like the brother or the sister who unfortunately had a cardiovascular event, who is having the injection, and the other patient who did not have the event but has a very bad state. His arteries are not in a good state, is wondering why he cannot have access to the treatment. So these are difficult conversations to have, but we are with the patients in that, and it's important to communicate and to discuss openly about that, because sometimes we don't have solutions, and this pushes us to improve and optimize as much as we can the currently available treatments.
Yeah, that must be very frustrating, both from the patient and the physician, not to be able to deliver what would be the best treatment. So I think that's where that's sometimes a gap between like the recommendation, the guidelines, and the practice, what's feasible at the end. So for you, would this be the biggest gap when it comes to guidelines and daily practice, like
Yes, I would say that these are the biggest obstacles, because otherwise, guidelines are very important references for us, and so if we were able to apply what's suggested in the guidelines, and if this applied to all the patients that are concerned by the guidelines and the specific pathology, this would be the ideal scenario.
Yeah. Okay. It's difficult, but I hope this will be simplified with the coming years and the new drugs coming, because there's always new products coming on the market. And going now to another personal local experience, I wanted also to have your perspective, Niraja, when it comes to maybe you can also explain a bit what you went through when it comes to your diagnosis and care treatment, and maybe also discuss some obstacles that maybe you faced.
Absolutely. Thank you, Marina. So I think my diagnosis journey also really shows this gap between guidelines and what really happens on the ground. I was first diagnosed in India while visiting my family last year during a comprehensive health checkup. So this was I was diagnosed with significantly elevated lipoprotein little a, and this came out of the blue. I had heard about it, but I had never considered getting tested because I thought if it was important enough, someone would tell me, maybe by doctor, or I would hear about it. So at that point of time, I was lucky to see a cardiologist back home who put me through the initial screening test, did a lot of follow-up assessments, and prescribed statins to ensure that my LDL cholesterol was aggressively managed. So the first thing I did after I came back to Germany was to go to my family doctor, and the feeling I had when I approached him was really disappointing because and Julia, you also mentioned that the guidelines differ, between what the GPs have versus the specialists have. And my GP was quite dismissive in the sense that he said, it's just fate, you cannot do much about it, you're just getting anxious for nothing. And I also felt that he was slightly discouraging when it came to statins. And he said, this is something that you have to take for life, so please think about the side effects. And it wasn't a very pleasant conversation. I was also not referred to a cardiologist or a lipidologist. However, I was not very happy or satisfied with that discussion. So I did a little bit of research myself. I approached another lipidologist where I had a completely different experience. So he looked at me as a person first, rather than as a patient or a case file. And I think I had almost an hour-long discussion with him. He went through the reports I had from back home. He did a complete assessment of my lifestyle, risk factors, family history. Also, made note of the fact that I was from India, so South Asians typically have a higher cardiovascular risk compared to the global population. And yeah, so I felt heard, and I felt like he was being empathetic. So when I compare the two experiences, they're vastly different. So I also realized that, of course, like GPs may not be the experts in that sense in treating dyslipidemias, and maybe that's the reason. But yeah, so this is what I wanted to share. So I also realized that I could not find myself in the guidelines because I'm in my mid-30s, I'm South Asian, I'm female, and even in the scoring algorithms, they start at age 40. So this is also something that I grappled with at the beginning as to where I stand and what exactly my guidelines are. And maybe this is also something I would like to ask Julia, yourself, and Antonio. What are your thoughts on that?
I think what you described is very nicely. So sometimes we tend to say, so the guidelines are the holy grail, but the caveat is it is based on the scientific evidence. And for the scientific evidence, you have to have the data, you have to have the studies. And young patients, female patients, or people, sorry, I'm always referring to patients, but in the end it's people, have not been well studied, and that is an issue. And this is why we do not find each and every one within the guidelines. And I'm sorry to hear about the experience you had. And on the other hand, I know this is very common, and this is not because that GPs are bad or whatever. There's 1,000 problems to handle, and you can only do so much, and everyone has their area of expertise. And yeah, we have to be aware, and we have to have better education, peer-to-peer, but also for us people, non-clinicians, we have to be aware that still cardiovascular disease, heart attack is the main cause we die from, and we know so little about it. We are not taught about this in school. But Antonio, maybe you have a different angle on it.
No, actually, I couldn't agree more. I mean, it's a real societal problem. I mean, cardiovascular prevention is such a huge matter, and we need to educate both citizens, patients, and doctors, actually. So there are a lot of initiatives, for this cardiovascular prevention strategies at national levels, within the hospital, within the centers, because it's such a huge, I mean, the population concerned is so huge that it cannot just, we cannot be just a bunch of experts dealing with this. It's something that needs to go in the in the common life practices. So it's something that becomes political. It gets political because it gets, it's about society, it's about common strategies. So we cannot stop insisting on how much we do not treat a number. Julia was right in saying that we don't find necessarily the patient the patient that fills all the cases in the guidelines is difficult to find because we need to accumulate enough evidence, and this is not that easy to do in a short time also lapse. But also what we have in the guidelines is like indications, so we can get a good orientation on the targets, on the number. So the patients that are very concerned because they are very, very well aware of their risk and their target, I also try to explain them that we do not necessarily treat the number, but we treat the risk. So it's even there something that is a bit different. So, diet, alcohol, smoking, physical activity still are extremely important, even if we don't see through that the effect on LDL cholesterol. I mean, the effect might not be that huge as the one that we can observe once we start a treatment, but we treat the risk and the duration, the engagement over time is also something that is extremely important, because having an extremely low level of LDL cholesterol for 3 months does not necessarily change your risk trajectory. So it's the engagement that we have over time in changing our lifestyle habits that really will change things in the long term. So this is all the communication process that we try to put on and to transmit to patients. So
thank you both. Jumping on what you both said, like that communication, education is very important, and that's also the reason of this webinar series, to inform more the community about these guidelines, and so that they're not only for experts, but that they're more accessible to people who are interested in this topic. And on this, Niraja, I was wondering, like, because with your experience, you probably had to maybe do some research, because when you have different feedback from different HCPs, it can be difficult. So you probably did some research. Did you check the guidelines, or if not, is it something you wish you knew about these guidelines, and be more informed and more aware to have the discussion with your physician using this?
So the first time I approached my physician, I really did not think of looking up the guidelines, or I didn't know that such guidelines existed, and I wasn't prepared for that dismissal. So when I went back and did my research, I felt like, oh, I wish I had known this earlier. I could have I would have been more comfortable advocating for myself and asking the right questions, because all I wanted, or as a patient, what I need is that the physician is communicative, is transparent about the decisions, is clear about what they want for me and what they are trying to achieve. So this is really critical information, which I would have probably received if I had asked my physician further some of those clarifying questions. So absolutely, the knowledge of the guidelines definitely helps patients. It's impossible to know everything, but the existence of the guidelines, or just at a high level, what is it that is relevant for my condition or my situation, I think that helps. Yeah,
that's very, very interesting to know that, yeah, patients feel comfortable at some point to get into these guidelines and maybe discuss them if they don't understand, but at least have the possibility to discuss them with their physician and understand like why they have this treatment rather than something else. And we discussed a lot about cholesterol, and even with your elevated Lp(a), you were also treated for reducing this cholesterol. And for Lp(a), there are no drugs available yet, but some are in the pipeline, and it should be available to patients, I hope, very soon. But we also have some people in the community with FCS. So Julia and Antonio, what about guidelines when it comes to this other conditions. So elevated Lp(a), was it something in the guidelines for a while? And when it comes to FCS, are there any specific guidance also on this in this 2019 guidelines? So Julia, maybe first, and maybe then Antonio more on the daily daily practice and it's implemented.
So both Lp(a) and FCS, they have a place within the dyslipidemia guidelines. It's a short chapter. And again, the problem is it's not Lp(a), but FCS, it's a rare disease. We have limited data. We just are on the verge to having like proper medication to treat FCS. So there's a lot going on, and this will get better, and also guidelines in these terms will get better. But currently it's very limited what you can find in guidelines or in general in the public domain on FCS. For Lp(a), Lp(a) is long known, but the issue always was that we had no treatment at hand. We were unsure, is it just a risk factor? Is it a risk modifier? Is it an incidence that we see high Lp(a) levels? So we have a lot of data now on that, and we are quite certain that if you have high Lp(a), you have higher risk of cardiovascular disease. But then there was always this reflex to say, but we do not have medication that lowers Lp(a), so we cannot do anything about it, neglecting the fact that we could use LDL cholesterol like a volume dial for risk to attribute, and also look for other modifiable risk factors.
Yeah, because as I understand, the risks, they just add up, and there are some for which you cannot do much, but you can act on the others to lower the risk. So I think, yeah, it's also something very important. I'm seeing that on the Q&A, we're receiving some questions from the audience. So I will share the first one with you now. So the first one is how to categorize people with no other risk factors besides Lp(a) exceeding 50 milligram per deciliter. So I think that's maybe for you, Antonio.
Yeah.
Or would you do that?
Okay, no, I will keep this one. I will take this one. So in this case, we are typically talking about what we call apparently healthy people, so people that do not express any cardiovascular risk factor. So in this case, we could think that people are at low risk, or at least at a non-increased cardiovascular risk. As Julia was just saying, Lp(a) is considered now officially a risk modifier. So there are some equations that help us, re-stratify the risk, and so reposition the evaluation of cardiovascular risk when we have some supplementary elements. So Lp(a) is one of these, and so we know that in this case our objectives, our target might be more ambitious if we know that we have Lp(a) that is increased, even if there is not a specific treatment for this lipoprotein. We would want to be more involved into all lifestyle habit changes, and if needed, we might start a treatment in order to decrease and optimize the control of all the other cardiovascular risk factors.
Okay, that's very, very interesting. Many people are sending questions on the chat. There's another one about asking, like, how do you support your patients with the lifestyle changes that they need to implement? So I would like to have both your point of view as physicians, but I also like to have Neeraja's point of view as a patient, like where you asked to do some lifestyle changes, and where did you really have some support from your physician to implement them? So maybe Neeraja, if you want to start.
Yes, I can get started. So I think my lipidologist in particular stressed the importance of managing other risk factors in addition to lifestyle modifications. So he also, Julia, the slide that you showed me earlier, right? So he talked me through the exercise guidelines, the Mediterranean diet, and he was super clear that all of these have an influence on your health, overall health. You may not be able to reduce Lp(a) because we don't have any medication that is that can be prescribed yet, but aggressively lowering LDL cholesterol, this was one of the aspects in addition to lifestyle modifications. So overall, I felt this focus on lifestyle in addition to medications. This is, I mean, it's also important for patients to know that one without the other is not as effective as both together, right? So yeah.
Thank you, Niraja. And Julia and Antonio, so you support your patient explaining that, because also it's sometimes not easy for patients like to have a treatment, but also to have some lifestyle changes. And sometimes with the lifestyle changes, you don't really see an effect on your LDL. So sometimes it can be very frustrating from the patient point of view, and could be like, okay, I'm just taking the drug and I'm forgetting about this lifestyle changes if they're not doing anything. So how do you cope with this situation and really support your patients?
Well, I want to say that this takes a lot of most of the outpatient visits, so it's something that is always addressed and talked through. And then it comes to a multidisciplinary also approach, meaning that sometimes when there is really a need to go a bit more in depth into the specificities of diet and physical activity, everything needs to be tailored. So this is my first thing. So there is nothing that comes, from up and that, this is what you have to do because this is how it works. Anything can be adjusted to what patients prefer. So this is where it comes, more interesting also from our point of view to find solutions that can really work for, that can really, better at best adapt to patients' daily life. So sometimes dietitians or physical activity educator can give us some help, but otherwise we can discuss it with the patients and try to find solutions that really fit their daily habits.
Okay.
Julia, you maybe want to add.
Yeah, I want to add, I love what you say, and I wish it were the same in our clinic or on my side, but I have to be very honest. How am I supporting my patients and lifestyle? Poorly. I'm doing it poorly. I remind them of the lifestyle changes they could do. I give them the respective leaflets. We have only very limited capacity for dietitians, so I have to be very sure whom I refer or not, to make sure they get an appointment in time. So it's hard, as hard it is for all of us to keep to lifestyle changes. It's also hard to support you with implementation. I can only try to educate and give you some advice, but like a proper program to support, I don't have access to. And one thing, because you mentioned it, Marina, just an addition, I want to make very clear that even though these lifestyle recommendations are within the dyslipidemia guidelines, through lifestyle, you do not lower cholesterol. You lower risk, but you do not lower risk through lowering cholesterol. That is to me, this is very important, because I have patients with familial hypercholesterolemia, young patients who said, I'm never going out to have pizza with my friends because of my cholesterol. And I say, but you could, it's just, please go have your life. So
it's a very good point and very good advice also for people that following the lifestyle recommendation is good, but you don't have to stop living and not enjoying things anymore. There's a balance also to be found, and it also depends on every situation, every patient. That's why also communicating with the physician is extremely important. like this collaboration between patient and physician is extremely important, and being able to discuss openly is critical in the long-term management. I have a question that's maybe a bit tricky, but so we have a question from Jean-Luc asking, like, what could be the role of AI in ensuring new guidelines and best practice are more widely available and implemented by GPs, considering the limited time?
Well, this is an excellent question, and actually is one of the current themes that come back when it comes to research in cardiovascular prevention. I mean, there are a lot of calls for a new research program that are financed by European Union, for example, that really call for this action. I think that we are all working on that, physicians and patients that are involved in co-constructing programs, research programs on that. AI could definitely help when it's supported by evidence, and when it can help tailor risk and go for a personalized approach that takes into account several aspects. Now, the thing is that to use these tools, you might need to have a lot of information. We need to simplify it. If this application that we can imagine might be used by general practitioners, have to be available and used in the current and common practice. So I think we are a bit far from that yet, but we are going in that direction. The idea is really to apply in the daily practice for physicians, for GPs, solutions that are efficient, and I think that we are all working on that. Julia, I don't know if you want to.
And I know you're doing a lot of research, and we are also collaborating on a very interesting project, FH Early, which is very, very important also for us. Julia, do you have also any comment on this? I'm just mindful of time.
I fully agree. So I fully agree. I think decision support systems for clinicians, so to give them a direction for a decision is fantastic. I think you will still need the clinician like a translator between the evidence and the patient. But also, I mean, for the documentation part, so we are currently setting a platform up just for the documentation part, and this will be so great, because then I have a version of a letter that is going to the GP, which is like medical German. Then I have a letter to the patient that is like lay terms. So this will be, I'm very much looking forward to that.
That's amazing, and I look forward to also see these progresses, which will be very good for physicians, but also patients. So as we just have 2 minutes left, I just want to let people know the people who shared questions on the Q&A, because there are still a lot and we won't have time to review all of them, but I will coordinate with our panelists and try to get the answers so that we can also share them maybe in the next newsletter from the foundation. I want to thank you all for this amazing webinar. It was very interesting, and I hope it was as interesting for the audience, but I've learned a lot. So thank you all for this really open discussion. I want to give maybe the last word to Niraja. If you were to give an advice to a newly diagnosed patient, from a patient to a patient, what would you suggest doing?
I think there is this nice little framework that I came across sometime in the past called BRAN, B-R-A-N. So the B stands for what are the benefits of the treatment, R for the risks, A for the alternatives, and N for what if I do nothing. I think this is a very simple framework that you can ask any doctor that you meet. It doesn't have to be your lipidologist or cardiologist, even a dentist, right? So this really helps patients have that conversation with doctors, and I use it a lot. Yeah.
That's a very good one. I think we need to put that also with the questions from that Julia suggested that patients should have with their physician. That's really great. Thank you so much to all of you. That was amazing. Just to keep the people informed that we have another webinar, the last one next Thursday. So with some other very interesting panelists. So I really encourage you to scan the QR code and register. It's going to be very interesting, and we'll go to the what's new in 2025 and why these updates and what is really important for the community. The recording of this webinar, as well as the previous one, will be on YouTube very quickly. And if we have time for the last slide, if you can answer the survey about this webinar, just to give us a feedback, what you liked and what you suggest to make it even better next time. So we will also share the link to the survey by email. But I thank you all for participation. Thank you for these amazing panelists that were here tonight with me. Thank you all for joining, and I hope to see you all next week. Bye.